Good afternoon, everyone, and a very warm welcome to today's DaRe2THINK webinar on antihypertensive therapy. Thank you first for your continued involvement and support in the DaRe2THINK trial. Today, we're delighted to be joined by Professor Kazem Rahimi, a professor in cardiovascular medicine at the University of Oxford. Professor Rahimi is a global leader in cardiovascular disease research with particular expertise in hypertension, risk prediction, and large-scale data-driven clinical trials. Today, we'll be sharing insights on the evolving landscape of antihypertensive therapy with reflections on evidence-based practice, international guidelines, and real-world implementation. Thereafter, we'll have a short Q&A session, and then Professor Katecha will give us some updates about the DaRe2THINK trial, where we stand and the way forward. Before we start, please note that we are using the Zoom webinar sort of environment, and as such, you're welcome to post any questions at any time, either in the Q&A box or in the chat, and we'll come to as many as we can after the talk. So without further ado, really, Professor Rahimi, over to you.
I have no conflict of interest to just for this presentation. To just kick off the presentation, let's start with a case study of 3 different patients that you might encounter in your daily practice. Patient A is a patient who has no prior cardiovascular disease, so is a primary prevention setting. Blood pressure recording average is 145/75, and the 10-year calculated CVD risk score with your typical Q risk is 15%. The next patients similarly have no pre-existing cardiovascular disease. For patient B, blood pressure is below the threshold of conventional hypertension diagnosis, 135/70. However, her predicted risk of cardiovascular disease is somewhat high, 20%. Patient C has a clearly hypertensive blood pressure, 150/85, but her calculated risk is lower at 8%. Now, just think about it. If you had these patients in your clinic and you had to just make some prioritization of not treating one of the patients, which one would it be? Which one would you deprioritize and offer no treatment for? So you can see the poll is going. Let's wait for a minute or so. Interesting. So it's quite balanced view on who should not be offered treatment. Okay. So 26% would not treat patient A, 41% the majority would not treat case B, and 32% case C. So, and just think about it, there's no poll on this. If the discussion would not be about antihypertensive therapy, but LDL lowering therapy, just think for yourself, would your decision be any different, your prioritization or not? Obviously, because for statin therapy, cardiovascular risk thresholds are a key indication about who should be treated. Let's move on to the actual talk about why you should care about lowering blood pressure. If you look at the statistics about the global burden of elevated blood pressure, when we think about it, of course, we know that this is a major cause of cardiovascular disease, death and disability, But something that is often forgotten, actually elevated blood pressure is the number cause of death of any cause. This is not just about CVD. This is one cause of premature death across all categories of diseases that we have. And there are about 11 million people who die of elevated blood pressure every year, with it accounting for 20% of death. Of course, it's not just about death. If one looks at disability and the loss of quality in life, even in that ranking, blood pressure comes at the top of the list, accounting for about 200 million disability-adjusted life years across the world. That was in 2024. And this is about 10% of all disabilities related to health conditions are attributed to elevated blood pressure. Of course, we're familiar with its burden on cardiovascular disease. And here we're talking about half of all CVD events being attributable to elevated blood pressure. And if one breaks it down, is about 54% for CVD death and about 50% for CVD-related loss of quality of life years. And one thing that I would like to flag, these statistics are based on the fact that risk of cardiovascular disease or risk of outcomes related to blood pressure start to increase if we go above the range of what is considered to be a lowest level of risk, that is 115 millimeter mercury systolic. And the other thing that I would like to flag is that these statistics only look at cardiovascular disease defined as myocardial infarction, ischemic heart disease, stroke, and renal outcomes. And this is what I would like to just go a bit deeper, to just look at the consequence of elevated blood pressure and its treatment effects, looking at different outcomes. Let's start first with myocardial infarction. What we know is lowering blood pressure with standard therapy is expected to reduce the risk of incident myocardial infarction, fatal or non-fatal, by about 20%. It reduces the risk of stroke by about 27%, and this is ischemic and hemorrhagic. And this is a key distinctive feature in comparison to statins. A lot of the time we just compare the two as those being having the same effect. But for statins, what we know, they don't lower the risk of hemorrhagic stroke. If anything, there is some suggestion that it might increase the risk of hemorrhagic stroke. But for antihypertensive therapy, there's a strong effect on hemorrhagic stroke as well as ischemic stroke. Heart failure, we know that it's got a strong effect, 28% prevention of incident and worsening heart failure. And again, this is a difference with statin therapy, where we certainly know in people with pre-existing heart failure, statin have got almost no effect, with 2 neutral clinical trials being published. And even in the primary prevention setting, the relative effect on heart failure tends to be modest. Chronic kidney disease, evidence of less strong, here in this case, 11% relative risk reduction. But these are the outcomes when we look at the burden of heart, blood pressure and its treatment effect that are typically considered into the statistics. But there's a whole range of other outcomes: diabetes, dementia, atrial fibrillation, valvular heart disease, and peripheral arterial disease, that are currently not taken into account into those statistics. And I'm going to go a bit deep on each component of those very briefly. So for diabetes, we have got strong randomized clinical trial evidence that reducing systolic blood pressure by 10 millimeter mercury reduces the risk of incident diabetes by about 20%. And this is across the board, across all antihypertensive therapies, but with a strong effect for RAS inhibition. Dementia, you know how much investment goes into prevention of dementia drug therapies, but to my knowledge, the only class of drugs that we have strong evidence from randomized clinical trials that has shown to prevent incidence of dementia just with a few years of treatment is antihypertensive therapy. And we've got evidence of a 20% relative risk reduction from individual participant data meta-analysis of some of the clinical trials that have collected that information. Atrial fibrillation, I mean, you know about atrial fibrillation, and it's a growing burden and importance. And we have here some randomized clinical trial evidence, the best evidence coming from the SPRINT clinical trial suggesting that intensive therapy reduces the incidence of atrial fibrillation by 26%. This is supported by strong epidemiological evidence showing a continuous relationship between blood pressure and risk of atrial fibrillation. That is, the higher the blood pressure, the higher the risk of future atrial fibrillation. And also Mendelian randomization studies where we assess the risk of incident atrial fibrillation according to genetic predisposition of someone having elevated blood pressure also support that effect, and there are network meta-analysis of BP lowering trials that go in the same direction. Valvular heart disease, this is another area in cardiovascular medicine where we see a rise in incidence of conditions affecting many older people. And here the randomized clinical trial evidence is not very strong, but we've got evidence from observational epidemiology, Mendelian randomization studies, and smaller studies to suggest that higher blood pressure increases the risk of not only aortic stenosis, but also mitral regurgitation. Peripheral arterial disease, the evidence here from randomized trials is modest. We have seen strong association between blood pressure and risk of peripheral arterial disease. And in a meta-analysis of 7 clinical trials, we have seen, at least for calcium channel blockers, that the risk of peripheral arterial disease is reduced by about 30%. For other classes of drugs, there is no compelling evidence, and this is to be done in the future. But I'd like to flag the comparison of those outcomes with LDL-lowering therapy, which are fundamentally an anti-sclerotic drug. If you look at diabetes, what we know from statins, not only don't they reduce the risk of diabetes, in fact, inducing diabetes is one of the major side effects. For dementia, so far, all studies that have been carried out, including long-term follow-up of statin therapies, have not shown a prevention of dementia. For atrial fibrillation, we've got conclusive evidence that statin therapy does not lower the risk of atrial fibrillation. For valvular heart disease, there have been at least 3 randomized clinical trials of statin therapy in people with aortic stenosis, and they have failed to show any slowing of progression of aortic stenosis in these patients. There is some evidence of affecting peripheral arterial disease in terms of cardiovascular disease prevention in people with pre-existing disease. This just shows that the 2 types of treatments are complementary. They're not covering the same spectrum of disease at a biological level. One is more likely to just affect atherosclerosis, whereas for blood pressure, we know that this has also hemodynamic effects that could reduce the risk of many of those conditions that I've listed here. So with that, the question arises, who should be offering treatment? Given the broad spectrum of the effects that antihypertensive therapy has, and also the high burden of elevated blood pressure on adverse outcomes, the selection of patients for therapy becomes important. Now, one way of making a decision about who should be offered treatment classically has been based on an individual's blood pressure before commencing therapy. And to just illustrate that, I have here divided into the left of the slide some hypothetical patients with baseline blood pressure categories from here at the bottom, from assuming 120 at baseline all over to 160 millimeter mercury. Now, let's make an assumption that all these patients are offered a couple of low-dose antihypertensive tablets, which is the recommendation. Instead of using one class of drug and going with full maximized uptitration of it, the recommendation is to have a combination therapy at lower dose, because the side effect burden is lower and the effect is stronger. If you make that assumption that they have all been treated with the same drugs, you would expect the blood pressure to be reduced by roughly about 10 millimeter mercury, which gets to these numbers. From 160 you get to 150, 150 to 140, and so on. Now the question is, what is the extent of expected relative risk reduction on major cardiovascular events in these patients? So starting with the clearly hypertensive individual, the relative risk reduction on major CVD is about 20%. Going down from 150 to 140, the relative risk reduction here is exactly the same, 20%. And you can see where this goes. It doesn't matter where you start from. The best evidence suggests that the magnitude of blood pressure reduction is what determines the relative risk reduction. Wherever you start, if you reduce the blood pressure by the same fixed amount of blood pressure lowering with the same intensity, the relative risk reduction expected is to be the same. So that just shows that blood pressure strategy is not a very efficient patient selection method. And this is also shown in terms of absolute risk reduction. The signal for blood pressure to identify people whose absolute risk is high has shown to not make any difference at all, as shown in this data from individual participant data meta-analysis. Not only that, what we also know that these individuals who are in the same blood pressure category can very different predicted risk of cardiovascular disease. And in one study, it was shown that it can vary up to 30-fold depending on demographics and coexisting risk factors. This shows just the limitation of using a single risk factor for deciding who should be offered treatment. But what we know is that people with higher absolute risk have got most to gain with. So in interest of time, I skipped through that. And there are, of course, tools for better identifying people who are at risk of cardiovascular disease. And we know that we can get much better in terms of prediction, replacing even some of the best models that we have, such as Q-Risk that we use. We can get better to identify people who are more likely to benefit from therapy, to select people for antihypertensive therapy or even statin therapy. Now, coming to the case that I presented initially. So if we look at those 3 patients again, as I said before, giving them a couple of antihypertensive therapies, starting with patient A, you would expect the blood pressure to be reduced by about 10 millimeter mercury, relative risk reduction 20%. That translates based on her 15% risk, would translate into an absolute risk reduction of 3% or number needed to treat of 33. If one does the same calculation for the next patient, the relative risk reduction is the same, but because she's at higher risk of CVD, the absolute risk reduction is expected to be higher and number needed to treat also lower. On the other hand, the last patient, patient C, despite the higher blood pressure, the expected relative risk reduction is the same, but because of her lower predicted cardiovascular disease, we need to treat many more such patients to prevent one cardiovascular event. So NNT is 63. So the question that sometimes comes here is just saying, you didn't tell me anything about drugs side effects or harms associated with treatment. And I just briefly mentioned that this is not going to make a difference at all. In this scenario that I've presented, the assumption is these patients will be given the same 2 classes of drug. So the drug-specific harms are going to be exactly the same among these 3 patients. There are, of course, non-drug class related harms, which are related to blood pressure. If you reduce blood pressure very intensely, you are going to see some hypertension and hypertension-related side effects. But in these 3 scenarios, as I've mentioned, the assumption is the magnitude of blood pressure reduction is the same. So again, this will cancel each other out across all 3 patients. This is not a key differentiator for treatment decision among these patients. And by the way, all 3 patients are recommended according to the latest ESC guidelines to receive blood pressure lowering therapy. So it was just a teaser at the beginning to force you to just think about how we would prioritize. I skipped through this in interest of time to just say that as to conclude, the benefits of blood pressure lowering, of course, go much beyond the prevention of atherosclerotic disease, and focusing on high risk, not high blood pressure individuals is the most efficient way of prevention. So I'll stop there.
Thank you very much for that insightful talk. I was tricked by that question initially as well. I thought pretty sure I'd start medications for each of these, but yeah, no, it's useful to to know. Any questions? We haven't had any so far. So I think one of the practical so what I didn't mention in the beginning was that Professor Rahimi has been part of the task force of the 2024 ESC guidelines for hypertension. And I guess my first question really comes from trying to match those guidelines, not really match them, but trying to um, maybe reconcile is a better word, possibly not, but trying to take aspects of those guidelines and match them towards the NICE guidelines. So, for instance, with regards to practical considerations such as combination therapy, which I think you've touched on in your talk, the ESC guidelines now suggest starting with combination therapy, but in practice in the UK, we often start with monotherapy. Essentially, I wanted to ask about whether we'd see this combination therapy approach becoming standard practice in the UK as well in primary care. What kinds of barriers might we still need to overcome to ensure that happens?
Yeah, it's a great question. I mean, one thing to just say that the ESC don't necessarily recommend a fixed dose combination therapy because this is not available in all countries. UK is one of the examples. There's actually a disincentive from pharmacy to dispense fixed dose combination therapies because they're paid per pill. So the more pills, the more payment. It is one of those perverse incentives in the system. That is why we don't have polypills in this country on prescription. But that is why the guidelines say just, if this is not available, still to prevent inertia and avoid the loop of prescribing one tablet, that not working, not seeing the patient for a while, and so on, that things are lost. By chance, the blood pressure might look better and you don't go into the next stage of therapy. Start immediately with one tablet from the three classes of drug: calcium channel blockers, ACE inhibitors, ARBs, or thiazide diuretics. So this is not adopted by the NICE guidelines that are currently still recommending a stepwise approach. And I've not been part of NICE committees. I can't exactly follow the rationale for it, to be honest.
Okay, thank you. Someone's mentioned that feels like NICE needs an update. When are they being updated? I don't know if you're aware. You just mentioned that.
Yeah, I think they have the hypertension guidelines by NICE were actually updated about a year and a half ago, or might be now 2 years. I don't know what the cycles are, but I would not be surprised if they don't adopt that approach, because some of the evidence that led to the changes of the ESC guidelines were available at that time too. I've been part of NICE technology assessment team, but not the clinical guidelines development. So I don't exactly know why they have followed that decision. And so I would not be too surprised if they don't exactly follow that. But having said that, with American guidelines following as well, that may probably adopt a similar approach to the European ones, the pressure on NICE will grow.
Right, there's another question that's come up. I know we're running short on time, but this is quite useful. They've asked, what are your views on discontinuing antihypertensive therapy in patients with frailty?
Discontinuing?
Yeah.
So this is an interesting question. So let me just tell you the guideline statement. The guideline statement says in all patients, if they have been tolerating antihypertensive therapy with no side effects, continue unless you've got any major concerns. In people with moderate or mild frailty, we know that in fact initiating therapy is likely to be beneficial. So we have had clinical trials in older people, and when they were stratified by level of frailty, we have not seen any differential treatment effects. There's one group of people with severe frailty where the evidence is simply lacking, similar to people who are very old, and very old is defined in the guidelines at 85 years plus. This is essentially the gray zone where you need to be careful and cautious and use your clinical judgment. But as said, if people are tolerating, the guidelines currently recommend not to stop them. just at your discretion. Having said that, the evidence-based, we ran a randomized clinical trial in older multimorbid people, and we added, in fact, antihypertensive therapy or removed it from them. It essentially was a complex intervention. And most people prefer to continue. As soon as you stop them, the blood pressure went up and they got anxious, just saying, I'm going to suffer a stroke. Whereas they were more likely to accept addition of tablets. But there are colleagues in Oxford who are just extending another deep prescription trial, and they've got a slight different view on this. So I don't want to bias you. I think it is a bit of a gray zone, to be honest. In particular, people who've got significant level of frailty and are very old, you need to be careful in these people. And certainly people who have had tolerability issues, and there are periods, by the way. I mean, we tend to forget about it. I mean, summer is coming now. Those older people are prone to dehydration, and with that, they're more sensitive to antihypertensive therapy. So taking a pause during these periods in these people, we should not forget about it. So, this is the gray zone where your input and judgment is required.
Thank you. There has been
There's actually a comment from Dell in the chat, which might be useful for get Kazem's view on, because I think that's a very practical question.
The question, I'm just going to read it out in case people can't see it. It's essentially asking about prioritizing highest uncontrolled BPs, and whether it would be better to instead calculate Q-risk 3, Q-risk 4 for uncontrolled antihypertensives, then stratify that way to choose to target those with the highest risk.
Yeah, I would certainly favor that. From the evidence that we have, I mean, just for people who are not aware of it, I mean, NICE currently recommends you should measure the blood pressure first repeatedly as recommended. And if people are clearly hypertensive, defined as 140 over 90, then you should risk stratify. And if the risk is additionally elevated, consider treatment. So this is a bit of a combination of the two, leaving a bit of a gray zone. If just blood pressure is elevated, you might have also high risk to be treated. And this question just says, how about starting just with risk? And this was the theme of the talk, that the evidence suggests if you're interested in efficiency and you want to deselect, the best way is to go with risk only, because some people with low risk, particularly lower blood pressure, particularly older people, are at incredibly high risk of CVD and they would benefit from it.
Great, thank you very much. That was clear. Should we just move on forward now in the interest of time? Thank you so much again for your talk. It was incredibly insightful. Should we move forward towards Professor Katecha's update on how the trial is going? That's all right.
Yeah, no, thanks, Asghar, and thanks so much, Kazem. It's great to hear insights on this rapidly kind of moving field, as well as others. So we started this seminar series quite a while back now, in parallel to developing the DaRe2THINK national kind of clinical trial platform that we're running across primary care. So thank you, and thanks for all our previous speakers. Just to announce in advance, the next speaker on the 26th of June, I think it will be Emma Svenberg. Emma's an international star. She's doing great work on AF screening, has run the really major clinical trials in AF screening and sort of the new technology to diagnose AF. So that will be the 26th of June, and Abby will send around the invites in the next few weeks. Maybe, Abby, you can just share the DaRe2THINK slides. I don't really have much to say. I think there's two groups of people here. The first are people who are aware of DaRe2THINK and perhaps those who are already part of the trial, and then the other group really who haven't had experience with that. We've been running the trial now for a couple of years. We've got over 1,000 patients. I think it's currently about 460 GP sites all across England. So phenomenal work. So thank you for those who are already participating. And there's a call to action at the end for those who didn't know or would like to join up. Just to say, this is proving to be a really efficient way of doing national clinical trials. We have a really efficient system for taking the data from your own healthcare systems to enable very quick randomization and recruitment into the trial. These systems have been developed with CPRD and MHRA, And we're currently recruiting only EMIS practices, but hopefully within the next few years, we'll be moving towards TPP System 1 as well. So we're really keen to get more engagement. If you're an existing practice and you want to hear about the latest updates, so we have a very quick and easy new system that will rapidly increase the amount of patients that can be enrolled, and also link in with a text messaging service. And of course, the more patients that can be enrolled, the more finances we can get to your practices through the RDN networks. And if you're a new practice, again, at the moment, only EMIS, I'm afraid, but if you're new and you're interested in taking part in a really innovative clinical trial with very, very low burden for clinical staff, particularly now we've got the new platform up and running, then there's a QR code on the right there. Otherwise, just drop the DaRe2THINK team an email, drop us a line. We're happy to have a very short call with you and take you through how you might be able to contribute. So sorry, we've ended a few minutes late, but I think it was really worth that extra few questions because Ian is the kind of one of the experts in the world on hypertension. We hope that's really helped your professional development and those of your teams. Please do circulate these webinar links to all of your colleagues. We're happy to spread to as many primary care sites and staff as we can around the NHS to really help what is obviously often a difficult subject around some of these cardiovascular conditions. So yeah, so final plug, the next one will be on 26th of June. And thank you all, and we'll see you soon.